So I'm a family practice doc, Brown and Toland. I've been a practice in the city for 30 years.
And most of them have already met you from the tour.
Yeah, I think so. So that part probably won't be that big.
I think one of the things too is just
Never good.
Yeah.
These folks have done some of this sort of thing. Well, but everybody is part of a big organization, and it's not the same process.
Oh, no, I mean, we have a great advantage of being, somewhat new. Although I have to tell you, going from a master and commander to part of a corporate structure, every day I find some reason why it's hard and kind of adjusting. And the payoff is obviously good, but obviously I'm like, oh, sure, yeah, this is hard.
Just have a calculation. They asked.
So, good afternoon and welcome. Am I just not being persuasive enough, or is this not on? Okay. That works. That works. Okay. I was afraid I wasn't being persuasive enough, so fortunately we've solved the problem. So good afternoon and welcome. It's really exciting to have you all here, and particularly those of us who've just come from the tour. I think there's a good deal of persistent excitement from that as well. So it's great to start off this way. We need a few more people sitting in the front pews here, because this is very interactive. That's the whole point. That's what collaboration and collaboratives are all about, is interacting with each other. So the more folks we can get kind of spread out and not feeling quite so isolated, that'll be good. So we'll start our formal NCETA collaborative in the morning, but we wanted to take advantage of the afternoon to do the tour, which we very much appreciate, and also a little discussion of PCMH models and some of the features that and the learning that people have acquired in that process. So I think that's, we have four formal presentations, brief formal presentations this afternoon. One from Dr. Shore at Brown and Toland, one from Cornerstone, one from Colorado Springs, and one from Billings Clinic. But a lot of you have experience and opinions and ideas about these topics, so please chime in, and we will make it interactive and want to have even more discussion at the end. We begin with Dr. Larry Shore, who's with Brown and Toland and had been a part of the Brown and Toland IPA as a family physician. And as Brown and Toland was thinking about, and he'll talk about the rationale and the history of this, creating an employed physician model and a PCMH practice, jumped at the chance and is leading it. And you can see from his enthusiasm why he was interested in doing that. So if you would, we have some slides. He's provided some slides. All of these will be available on our web portal.
Good. So a lot of you already heard what I have to say, so I'll go through the parts that seem familiar, and hopefully there'll be some time at the end where we can have some questions and so forth. These are the things that I want to talk about today, a little bit more formal presentation to supplement the informal one that we had on the tour. So there are lots of definitions. I kind of like this graphic. It's simple, and it talks about some of the key elements of creating a medical home or advanced primary care type practice. The names vary depending on who's the certifying body. We have a lot of these parts in place, and I'll talk about some of them as we go along. This practice was formed in the beginning of 2012 after a long board discussion at Brown and Toland about where were things going, where do we need to do. Everybody recognized that primary care was a problem. The average age primary care doc in San Francisco is my age, which is to say slightly over 50. And there's going to be retirement. There wasn't a good mechanism to bring new family docs, new primary care docs into town. And so we were looking at what can we do better and what's a good way to get family docs to come to town. So once the board had a discussion, an offer was made to 45 of the primary care docs in Brown and Toland who represented the most active, largest panels, invested in the electronics and so forth. I would say that most of them said, sounds really interesting, let me know how it works out. And then we came down to 4 who were willing to give it a try, and that's where we started. The space that you saw was an empty shell of former governmental office and was converted in 12 weeks to the way it looks now. So it's a pretty amazing construction project, particularly including the electronics that are hidden behind the walls. So we brought the pre-existing practices of 4 doctors to form the new practice. My practice is about 30 years old. Dr. Bandari has been with me for 7 or 8 years. Dr. Khanna has been in the community for about 10, and Dr. Lindis a little bit less than that. So the initial staffing looked like this, and in our initial model, we did have an LCSW who we currently lost to Arkansas. Her husband wanted to start a restaurant there, so we lost her. We hope to replace her pretty soon. But you met our data analyst, but didn't meet one of the key people, which is our care manager, Don Surratt, who is spectacular and makes a lot of the difference about why this practice is different than other practices. And then the other roles are clinical medical assistants, who are traditional MAs who are working at a very high level, and what we call patient service coordinators, which is the typical check-in, check-out, phones, and some of the other administrative roles in the office. We have evolved from that initial concept now to the team, which I mentioned in our tours, of combining a physician and a nurse practitioner along with the clinical medical assistants to form teams within the overall practice. The care manager is doing a lot of the complex transitions of care work. We identify particularly high-risk patients, and she does one-on-one outreach. And she's also the leader of the Population Health Management Initiative. And then our data analyst has been doing an amazing job of converting, what I said, pencil and paper into electronic systems. So we'll talk a little bit about the care model. This is a graphic from Sharp Medical Group, and I kind of like it because it has a lot of the things that are important about PCMH. So those of you who work in a PCMH will recognize this. Those of you who are thinking about a PCMH, this is the kind of things that you need to do. This is the kind of projects that you have to organize, the kind of responsibility that you need to take for the population that you provide care for. And each one of these things, they seem self-evident, but they're sort of hard to do when you go from the traditional fee-for-service, take care of what's in front of you kind of model into this more comprehensive population-based model. So each of the roles has transformed. For the staff, now each of the job descriptions have formed teams, and they have team meetings about their role and their job and how to make it better and how does it interact with the other teams. We have the physicians being as data-driven and evidence-based as we can be. And that, as you know, that changes and updates all the time, but we try to use that stuff every day with each doctor so that we're consistent across the practice. One of the biggest transformations of roles is the patient role transformation, the idea of supporting self-management and supporting engagement and teaching skills rather than just telling people what to do. And you saw in our action plan, that action plan is an outgrowth of that concept. So we think that our teams will function better if we change the roles from what it's been in the past. As I was mentioning on the bus over, I was in a co-practice with a nurse practitioner for about 10 years, and it worked perfectly well, but we didn't really divide up the roles. The patient saw whoever was easiest to see or whoever met their needs that day. I think going forward, using the rubric of working to the top of your license, we're going to see more and more of the complex and unstable patients be seen by the physicians, more of the stable chronic and preventive health be seen by the nurse practitioners, and the really stable ones who don't have to be seen, not be seen at all, because their stuff can be managed without them having to come in through electronic contacts and outreach from the care manager. There are a lot of workflows that are inherent in a patient-centered medical home, and these are some of them. I mentioned some of them on the tour, but I think the team huddle is the one that's best developed at our practice. It's something that I was doing in my previous practice for about 5 years, and it's the day before the scheduled visits, the medical assistant is combing through the electronic record looking for those things which need to be done. It's called gap analysis. And she writes it down on a paper form, it's still manual, and then we use that the next morning in our team huddle to talk about each patient and what we're going to do that day, independent of what they're actually coming in for. So that's often referred to as in-reach. And it's a pretty effective method, but it works only for the people who actually come in face-to-face. You have to complement that with actual outreach, and outreach has to be data-driven. So the process is that the CMA starts the note. So the electronic note is owned by everyone, and that sort of speeds up and focuses the physician on what the person's coming in for that day. We have the patients participating in self-management by reviewing their problem list and reviewing their medications. Sometimes it helps us find out other drugs that were prescribed by other doctors who are not on the system, or medications that never actually took, or medications they don't need any longer that we just don't have any way of knowing that. Reviewing the problems is kind of interesting too, because there are problems that should have been retired a long time ago that end up getting addressed at that visit. So every visit, every time, med list is reconciled, problem list is reconciled. The clinical summaries is something that's required for meaningful use, and that's baked into all scripts, and we use it for every patient, every visit now. And I think that's become a good rhythm. We've altered the way that we use the note so that the plan section now becomes basically a letter from the provider to the patient saying, this is what we talked about, this is what the plan is, this is what I'd like you to do, and I look forward to seeing you back in a certain amount of time. So the plan section is no longer written in medicalese. We use the assessment section for that, and therefore the clinical summary becomes a useful document. It's sent to the patient either through the portal or through the mail or both. Access is one of the most important things in terms of patient experience, and we've worked really hard on access, and I'll talk about that in a little bit more detail later. The patient portal I mentioned several times today, I think that's really one of the futures for this type of care, but it has to be a modern portal. It has to be really quite flexible, platform agnostic, look nice, work nice, and have the right information in it. And then we do make a strong effort to get results out to patients. We say less than 3 business days, but it's usually the next day. And our pattern has always been to report every result to every patient all the time. And I think that's one of the things that is well received, because it removes the doubt of, am I okay? Was the test really okay? They would have called me if there was a problem. So the building blocks is something that I referred to. You saw my glass wall with all the stuff taped up that's important to me. The building blocks is an article written by Tom Bodenheimer and others at UCSF that talks about what you need to do advanced primary care, whether it's a patient-centered medical home or not. And it always starts with defining the patient panel. So the patient panel is the basis of everything, and we have a methodology for doing that we call the U18, which I referred to, and that's working pretty well. It allows us to know the size of the population we're taking care of, and it allows us to do staffing in a more reasoned fashion. The biggest challenge with panels, of course, is we have a fluid population. People move in and out of healthcare plans, in and out of the area, and sometimes have no insurance. So it's not as real-time as we would like it to be. The other thing which I think is exciting is risk adjusting, and fortunately there is a program within Allscripts that allows us to risk adjust the panels. And I think that's a better way to do staffing and to understand why one doctor sees less patients but works more. And it's not just because their patients are sicker, they actually are sicker. It's not just an impression, it's actually data-driven. So the other thing that we wanted to know is, so what should the panel size be? And you probably heard me say that, but this is the information that we got from the literature, that a standard panel for a full-time doc is 1,800 patients. And then we use the CMS ACO algorithm to assign the patients, and so we know who belongs to who. And they can float back and forth, and we refresh the panel every quarter. We use the nurse practitioner to expand the panel size, but we count them as less than an FTE. And we borrowed a number from the Veterans Administration in this regard. The veterans consider an FNP to be 0.75 of an FTE physician, so we use 0.8. So this is the formula, and this seems complex, but it's really not. And it shows how you can adjust the panel based on FTE status of your providers and also severity of illness. So if you look at the two paragraphs, it kind of makes it obvious how the numbers work out. And we're using this now, and I think it allows us to staff more appropriately for each team and also understand why some teams have more documentation work, non-face-to-face work than others. So we had several goals when we got started. The triple aim is something that drives us, and you all know about this, and I'll just restate it because it's important. It's improving the patient experience, improving patient outcomes, and bending the cost curve. That last one's pretty challenging. We have 4,500 patients, and if we bend the cost curve, it may be imperceptible. But if we go to 45,000 patients or 450,000 patients, then 2 or 3 or 4% reductions make a huge difference. And you may know that there was a report released 2 or 3 weeks ago called the Berkeley Forum, talks about state initiatives in California on how to bend the cost curve. And it's really quite an amazing report. It's about 70 pages. We also had other sort of personal goals: to be the first NCQA recognized level 3 patient-centered medical home. And there are other certifying bodies, but that's the one that's best known, and that's the one that most insurers know, so we went with them. And we retained a consultant out of Colorado called Health Teamworks to help us do that work. And they were very effective, and I think that they allowed us to do it much more rapidly than we would have done on our own. We were able to complete the application in about 7 months and then got certified in February. We also had goals about quality performance, being in the 75th percentile, including Kaiser in our catchment area for comparison. We want to break even because Brown and Tolan has been very generous, but their generosity has limits. So we have to demonstrate that the model is self-supporting. The big problem, of course, that most of our funding comes from fee-for-service. Only 40% is capitated. We would do much better if we were fully capitated with a care management fee that was appropriate for the work being done. And I think that's the way that everybody would like the industry to go, but it's going to be a big challenge to move from that which we are familiar with, even though we know it doesn't work. One of our other goals is to bring new bodies to San Francisco, new primary care docs, by offering them a professionally satisfying, forward-looking, exciting place to work that, oh, by the way, pays enough so you can actually afford to live here and pay off your debt, really. It's a pretty big challenge. There have been very few new PCPs coming to San Francisco, and the ones that come here mostly because they have to live here. There are family or other connections that make it that they have to live in San Francisco, and they're willing to take the financial hit to do that. But you can't really count on that. You have to have, I think, a better long-term plan for replenishment. And then ultimately, of course, Brown and Tolan is investing in us to create things that will spread to the rest of the network so we can do a better job across the network on all 3 aspects of the triple aim. So I want to just demonstrate one thing that we worked on of the several things, and this is under that first aim, improving the patient experience, and it had to do with access. I think in many traditional fee-for-service practices where you're always worried about an empty slot, you start the day full and then cram people in the sides, right? For those of you who've been in practice for a while, you kind of remember what that was like. It's a harried way to work, and it's part of the hamster wheel experience in primary care. We decided that that wasn't the best way to go, so we used data to drive us into how to make the scheduling work better. So we used the modified open access concept. We measured our same-day demand and then adjusted the schedule so that every day starts out about 65% full, and then we have different types of urgent appointments to use. But also by adjusting the schedule, we made it easier to schedule appointments. So you can see where we started out is an average of 13.5 days for the third next available a method of measuring that. And then we did the Plan, Do, Study, Act thing, which is, for those of you who've seen that, this is kind of a common way to do lean management. It's the same idea. And we're able to make some changes. We were able to reduce the third next available from 13.5 to 4.3 days. And the range, which remember went as high as 35 days for one of our providers, has come down substantially. And the busiest provider went from 10.3 down to 1.7 days. Our goal was 2 days, so that we could sustain, on an average basis, no more than 2 days for third next available. And patients were happy with that because the access became enormously better, and the schedulers could start saying yes instead of no. Their job is very stressful when you start with a full day and you're trying to cram people in the side. Third next available, when I made this slide, it was 2.5, has now come down to 2.0. Patients get in the same day 85% of the time. That's actually improved a little bit since I made the slide. And the other thing that was done, which is a parallel initiative from Brown and Tolan, was to open an after-hours clinic. The point of after hours is to provide service that's regular doctor visit type stuff at unregular times. People don't have to leave work. They don't even have to be part of our practice. It's open for everyone in the city. And it's appropriate for those people who don't need an IV and don't need an X-ray and don't need emergency room care. And some estimates say that that's probably 50% of the people who walk into emergency rooms. They go there because they don't have any other choice because of the time of day. And in some measurements of the patient experience, we're doing okay. As I mentioned on the tour, we use Press Ganey as our vendor for patient satisfaction. And on the one, if you've seen them, they're very complicated reports, but one overall question we seem to score pretty well. And we have internal marketing data that has been able to distinguish the My Health Medical Group experience for patients apart from the average one. So we seem to be heading in the right direction. So clinical outcomes, well, you might notice the name up there, Humedica. So we're very happy about where things are going and very excited about where the future is going to be as we get more and more into automated quarterly reports to tell us how we're performing in a number of different spheres of medical practice. So some of it is going to be chronic disease, some of it is preventive, some of it is immunization, some of it is disease monitoring. I showed you the diabetes pursuit, well, the basis of the pursuit list, and I think that that's going to be a very useful tool. What we're doing now is really the data vetting stage, where we're really getting down into chart-by-chart review to make sure that the data that we have is reliable. And as you all know, that's a fairly tedious process. But eventually, you become able to trust the data and then make, I think, solid decisions. The execution of the pursuit list is up to the care manager to organize, and it rests primarily on the medical assistants and the back ops people, whether it's phone calls or bringing people in or scheduling appointments or sending lab slips out to gather data that's missing. I show this because it's just a simple graphic way to understand how you're doing. So this is set up so that the green bar represents our target, and that's 75th percentile for the IHA standard for that particular measure. Each of the physician-led teams has its own color, so you can see how your team is doing. It's transparent. Everybody knows how everybody else is doing. And then we have one for the overall practice. And when you see shortfalls, you wonder, what's that about? So the graphic raises questions. And as I was mentioning here, the one that looks like we really performed poorly on, which is urine for microalbumin, it turned out that it wasn't necessarily a clinical problem, it was a data collection problem. So the right question was asked, but it came up with a different answer, which was still a useful process. We had a good first quarter. We got the NCQA recognition, and then the California Academy of Family Practice recognized us too, which was a complete surprise. So we got a plaque. That's kind of cool. And CAFP has been very active in promoting PCMH. They have a project going in Fresno now with the Fresno Unified School District, which has demonstrated pretty impressive cost savings as well as clinical outcomes. CAFP is also partnering with some of the vendors who provide consultation for transformation to help practices across the state move in this direction. We're also connected to another group called the California Advanced Primary Care Institute that is part of CAPG, which is where all the big medical groups kind of get together, again with the same idea of improving how primary care is practiced with a benefit to all. So what's next? Well, we have a few more things to do, and this is going to be very interesting next couple, 3 years. We need to get our LCSW back. Not having an embedded mental health care person is really difficult. I didn't realize how difficult it was until I had her, then she left. In private practice, you don't usually have that kind of setting, but working with her and being able to have someone who could meet the patient in the office to address mental health issues and coordinate mental health referral is huge. And a lot of chronic disease is complicated by mental health issues. We really are excited about the patient portal, the Jardog's product called Follow My Health, and we really would like to see almost universal enrollment. I think that supports engagement and it supports self-management, and it supports a lot of things, and it also allows for more efficient care providing that's not face-to-face. In my typical day, I might see 15 patients, but answer 8 to 12 emails, and whereas those people would all have to come in for what might not be such serious problems, but they still needed some evaluation. I think that we want to incorporate patients in the patient-centered medical home. So we want to incorporate some of our patients in our quality initiatives. And we started that recently around the issue of motivational interviewing. We had one of our patients participate in the activity. It was kind of liberating for everybody, I thought. The medical neighborhood is a whole other project, and that's identifying those specialists who believe in the model and understand the value of co-management and how that can be more efficient, and how you can basically set the table for the specialist. They take care of the meal, give you the patient back, very efficient. Defining who the medical neighborhood is going to be an interesting process, and I hope that will be somewhat data-driven. It's going to be driven to some extent by who's on the electronic medical record already. And then, of course, if we just succeed in this small practice, we'll be happy and proud, but it won't have an impact. So we need to go from 4,500 patients to 45,000 patients. We really need to spread these practices. Whether or not other practices become PCMH or not is not as important as adopting the workflows, I think. And if they become PCMH, so much the better in terms of negotiating future contracts. The question that remains in my mind is whether it's more efficient to do that by transforming existing practices or replicating what we already have. And I think that's a discussion that will come back to the board of directors of Brown and Tolan in the very near future. So we have a happy crew, and we're doing good work, and it feels great. And I feel revitalized at the age of 61 to be doing practice like I always thought I would be doing. So for those of you who are young in primary care, look into it. It's kind of a good way to go. For those of you who are in charge of organizing this for your institutions, it's great. Do it. Just don't wait. It's the right thing. Thanks. Oh, good. Microphone. Great.
Is it on? That was a superb presentation. Thank you very much. I love coming to the collaborative meetings because we get so many good ideas. One of the questions I had for you, we're doing a lot of very similar things. We're trying to risk stratify our panels and figure out the right panel size. You had in your equation, it was 1,800 MD FTEs plus 1,800 NP times 0.8 over risk ratio, and I was wondering what you use for that risk ratio.
We're lucky in that that's a number that's calculated within Allscripts using a program called Care Analyzer. And the numbers in our practice right now are between 0.7 and 1.7. So our youngest colleague, who has all the young, beautiful people who aren't sick, she's a 0.7. And because that's less than 1, she actually has larger panel capacity than 1,800. My colleague, Dr. Khanna, has a 1.7. And so when you look at that 1,800 and divide it by 1.7, hers count heavier, and therefore a smaller number of absolute bodies is more appropriate. So but it's a rolling calculation. It looks at the previous 12 months for your patients. So again, it comes back to who's your panel, right? Who's your panel? And if you got to identify the panel, then you can get the care analyzer number refreshed every quarter.
And that's not embedded in the Allscripts EMR, it's added on? Okay, yeah, thanks, Adrian, yeah.
Yeah.
Care analyzer runs off the ACG risk model, is that right? So the Johns Hopkins risk model.
So it's HMO only, but it has a lot of data in it from lab. So it is HMO only, and that's where we do extrapolate and say, oh, well, 40% of Larry's patients are with this risk score. I think we can fairly assume it's a fair estimate of what his whole practice looks like. So we use that number for all patients then.
Are you close to breaking even?
Sure. Well, I have other hats, as you might imagine. I'm also on the board of directors of Brown and Toll, and I also chair Physician Compensation Committee. So I'm trying to move the needle on physician compensation a little bit more towards care management and recognizing the work that's done in a PCMH. So where we're going to show the best, I think, is PMPM savings, particularly on the Medicare population. And we have really good numbers that I can't share. They're very encouraging. So I think as long as Brown and Tolan looks at us from a global perspective, and Brown and Tolan is moving towards a heavier and heavier risk-bearing organization, I think they'll see the value of the model when you look at total cost of care. Does that answer the question?
What about hospitals relationships? You mentioned the medical neighborhood with specialists.
Yes, hospital relationships. Very interesting. Our hospital, our main hospital, is part of a larger network, which is the Sutter network. And of course, Sutter has their own designs for the future as a hospital-based system, and they are our frenemy. They provide good care, but they also have their own foundation in town where they've bought up the practices of various doctors who saw that that was the way to go for them. Their foundation is not adopting this model so far. It's still pretty much of a production-based, fee-for-service kind of model. And don't worry about hospitalization rates because that's okay because we're the hospital and that's what we make our money doing. So their incentives are not necessarily aligned with the triple aim. So we have historical relations with them that have been better or worse depending on whose ox is getting gored, I think is the right way to look at it. And as we look about taking risk in the future, Brown and Tolan is doing a limited Knox-Keene license, which is kind of a California thing, that allows us to do the Pioneer ACO project. But Sutter's looking at a full-fledged Knox-Keene license to become a health plan and just cut out the middleman. So this is kind of interesting that, it's these two organizations who work together have parallel and somewhat contradictory plans, but we seem to work it out, after some fractious discussions. We use their hospitalists, for example, and the hospitalists provide great care. What we're missing from the hospitalist is connection to Allscripts, so that they can go online, see what's going on, send us messages in real time while they're taking care of the patients. But it's a project to get that kind of access set up, and there are all kinds of issues, not the least of which is that our hospital, CPMC, is going live with Epic. And then it becomes the project of making Epic talk to Allscripts and Allscripts talk to Epic, and that's Adrian's going to fix all of that one day. Yes?
How do you manage the PMPM when you're doing referrals to specialists? So part of the challenge we have is when we refer from primary care to our specialists, sometimes they are only referred for the oil and filter change, but they get the 16-point check, which drives the cost of care.
Right.
So how do you manage that?
So the answer is, I think I know how I would like to manage it. I think I know the data I would like to have, but I don't yet have that data on a per specialist basis. When you see specialist notes and you see the outcome and you see the testing that's ordered, because it's all there, it's a shared record, over time you develop an intuitive sense. And over time, I have intuitively drifted to those who seem to be more efficient, fix the problem, give them back. But I think that we could be data-driven in that regard, too. So creating the medical neighborhood is a huge project, and to make it data-driven and transparent is a politically challenging project. transparency is going to be huge, I think, for all of us going forward, and we just have to embrace it and get over it and move forward. Cool. All right. I'll be around afterwards if you want to talk. Thanks very much.
If we have any particular order, John, are you going to go next, please?
I don't want to follow that act, that's pretty tough.
Order stuff. Yes, I believe, let's see, it should be in a folder here.
Dale could probably handle this.
It might be.
Thank you, John. So I'm John Walker. I'm the Chief Medical Officer for Cornerstone, and as we're talking about building medical homes, I thought I'd tell you a little bit about some of the things that we've done. Glad to see a lot of the things that we're doing at Cornerstone are very similar to what they're doing at Brown and Tolan, and in speaking with some of you today, a lot of the other groups are doing very similar things. I think that's very, very comforting in a lot of ways. When we started on our journey, we had to get our physicians out of their comfort zone and get them to where the magic happens. And as you all know, that can be a real challenge because the fee-for-service world made intuitive sense to a lot of people. I do something, I get paid for it. And now we're talking about moving to this fee-for-value world where you're going to be doing less of something and I'm going to get paid the same or more. And so some of our physicians are having a tough time with that, and we have to work them through that process. But we at Cornerstone, we do believe that the fee-for-value world is where the magic really will happen, and we will hit the triple aim with that. So again, we just heard a little bit about the triple aim, so I won't go to that, but we actually have what we call the fourth part of the triple aim, and that's physician satisfaction. And we really think that as we transform our primary care practices and extend that to making a medical neighborhood involving our specialists, that the lives of our physicians will get better. And you heard good testimony before about the positive effect this can have. We're seeing some of that too. So we really believe that the care transformation and moving towards fee-for-value is going to be very important in retaining physicians' satisfaction. This is our PCMH roadmap as it stands so far. I think the first piece of it was really when we went on the EMR, and we were also on Allscripts, and Adrian and I have commiserated about that on many occasions. In 2007, we did one of our first medical home type things and began to do some extended hours. In 2009, we developed an infusion center, and then we really started to educate the physicians and the staff on what it meant to be a medical home. A key part of it was when we went live on Umedica in 2010 in December, because that actually gave us the population health basis that we could build out some of our medical home projects. And in March, as I've talked about before to you, we developed our patient care advocate program, and then we broke down into service lines in July of that year based on specialties, primary care, adult primary care being a large focus of some of our transformation efforts. And then in October of 2011, our shareholders voted to move to a fee-for-value system, and we have invested heavily in that. And no, we haven't broken even yet on that, whoever asked that question before. So we strongly believe that mere recognition of someone as a patient-centered medical home practice does not equal function. And completely agree with our colleagues from Brown Tolan that the true medical home has a lot of different aspects to it, including things like care coordination, health navigation or case management or care management, whatever you want to call that, advanced practice providers as a key part of the workforce, clinical pharmacists as a part of the workforce, behavioral medicine. Also, we believe that needs to be a strong component, and of course, and social work as well. All of Cornerstone's practices that were part of Cornerstone prior to December 31st of 2012 were recognized as level 3 patient-centered medical homes. On the recognition side, we're in the process of transforming them into true medical homes. we've taken a little bit of a sort of a medical neighborhood approach to this at the outset, and part of the reason that we chose to do this was because we saw areas of opportunity in different patient populations that with our move to fee-for-value and getting all our contracts to gain share, that we might be able to capitalize on some of those patient populations. We are fortunate, as of 3 weeks ago, when Blue Cross, or as we'd like to call them, the Blue Ooze, finally signed our gain share contract, we were able to get all of our contracts in fee-for-value type contracts with gain share. We are moving very quickly towards full risk because we believe that in order to sustain some of the investment that we've made, we're going to have to do that. But we have developed several different clinical models, including a heart function clinic to take care of heart failure patients. We've completely transformed our cancer services. We developed a care outreach program to deal with dual eligibles and also our Medicaid patients in our area. And we're actually going to try and partner with UNC Healthcare, which is the new owner of High Point Regional Hospital, to do an indigent clinic. We're developing what we're calling our personalized primary care program, which is our model of, it's like an advanced medical home type model for all of our practices. And we also are developing an extensivist clinic, which we call our life care clinic. All of these different models, this medical neighborhood, if you will, have been designed by the physicians along with some consultants that we utilized initially, but now it's all physician-driven. We have design teams which include the physicians in the respective specialty and the support of the administrative staff. The consultant support that we had in the initial part of the project is now gone. The team is led by physicians. We, in the oncology and cardiology models and some of our initial primary care models, we actually had embedded psychologists. We found out that didn't really work all that well. And so we're changing that model to go more towards LCSWs. Behavioral health has got to be a key component. Depression has a significant impact on chronic disease. We found that there was a little bit of resistance to the concept of the psychologist being there as part of the team. And so we are actually going to change that model and make it the LCSWs. And I actually would be interested to hear if anyone has made the psychologist as an embedded team member really work, as opposed to just there in the practice and referring to them. We plan to embed pharmacy services with a clinical pharmacist and to do not just medication reconciliation, but comprehensive medical management. We are planning on doing some of this with the pharmacist right there where there is sufficient polychronic patient population within a clinic to merit that, and we're going to also do some of this via video conferencing. We have health navigators deployed in all of these models. Some of these are embedded in the practice, and some will be remote and function more like care managers. Of course, nurse practitioners and PAs. We've got some nutritional services, and we're deploying social workers in more of a hub and spoke model to deal with a panel of the practices. So just to go through sort of exactly our timeline here. Last year we did our fee-for-value contracting. In March we had the heart function clinic designed. And in July, that was implemented. In April, we started the design for the cancer services, and that was implemented in August, which I think I left that. Oh, there it is. Okay. In July, we began our primary care redesign meetings and implemented that in November. This year, we've got the Care Outreach Clinic, which started up and running in February. We're going to have our extensivist clinic open in May, and I'm interested to hear from, on tomorrow's part of the agenda, how some of the other extensivist clinics are going to be looking. I mentioned clinical pharmacy. We're also working on our transition of care program, wellness, and other population health initiatives, and some issues around getting all our diabetics who need screening, getting them done, because that proves to be a challenge for us. So, quick overview, but I was told to keep it short. And so, a couple questions for you to sort of stimulate discussion. What are we missing? And the second question is, what does your team look like to get your practice is recognized? Is it an implementation and then recognition, or do you, so just a couple questions for you, and I'm happy to answer any questions that you have for me. Thank you.
How would you define the difference between use the words care coordinator versus health navigator? It may be a subtle nuance, but I think everyone's using different vernacular. What is the distinction at Cornerstone?
Great question. Thank you. And I actually left that slide out, and I meant to put it in there. We've got several different people are becoming part of the care team. Our health navigators are functioning more in the role of traditional case management. And they were not initially, but we found out that some of the thoughts that our consultant had on what a health navigator could do were too clerical in nature and really not to the top of an RN's license. They're all RNs. So we've morphed that role into more of a traditional case manager. That actually has allowed us to either have them embedded or have them external to the practice. We've got our patient care advocates, which are the outreach folks. We have patient engagement coordinators, and they function like internal patient care advocates. They do a lot of outreach, they queue up the charts, they help close gaps in care. So that's sort of the distinction. We don't have anyone that we actually call a care coordinator. We've got some of those things parsed out amongst different members of the care team.
I have another question.
Yeah, please.
A question I've heard from a number of groups is, what's your current ratio or thinking as you're staffing the different practices in terms of the ratio of the health navigators to the panel size, et cetera?
So this is, at Cornerstone, we like to say we're building the airplane as we fly it. Because we really are changing a lot of these things, and what we started out with is very different. So for the heart function clinic, with the intensity of illness of those patients, we sort of targeted 150 to 200 per health navigator, and that may be a little bit on the generous side given the level of complexity. We're finding that in the oncology patients, because of the nature of their illness, the ratio needs to be lower. So we're actually looking at probably 100 or less per health navigator in the oncology clinic. In our primary care models thus far, again, initially we thought we talked about 500. That was wildly overestimated. So we're looking at the 150 to 200, 250 range. And then what we're doing is we're pairing the patient engagement coordinator with a health navigator. They will work as a team to do sort of what we're calling comprehensive care coordination. And so a lot of the outreach stuff, the quick phone calls, the queuing up the gaps in care, that's what the patient engagement coordinators are going to do and take that function away from the health navigators.
What's the title of your coordinators with RN,
Our health navigators are all RNs. Our patient engagement coordinators are CMAs. And the patient care advocates are all CMAs also.
Hey, John, excellent presentation.
Thanks.
So what happened with physician satisfaction? Are you measuring it, and are they liking the changes, neutral, some not liking it?
The people who are, the physicians who have been in the clinics where we've done the transformation, and they have the opportunity to spend 30 to 45 minutes with a very complex patient and have a navigator help them out, they have found the joy in medicine. There's just no other, they absolutely love it. And so what our challenge is to do in a cost-effective way to get that feeling for all the other doctors in Cornerstone. And I don't know, with the number of patients we care for, it's going to be hard for everyone to see 15 patients a day and still take care of our entire patient population. So we are incorporating more advanced practice providers, but we also are looking at, for an individual provider, physician's patient panel, if they've got, let's say, 2,000 patients and 300 polychronics, we're using Charleston score provided by Umedica to help us define that. We're trying to figure out how much time per week they need to see those polychronic patients and just schedule them for a longer period of time and have the support services wrapped around them or available telephonically to help them, continue on some of those, with some of that care coordination effort. Does that make sense? But, so far the physician satisfaction looks great for the people who've done it. The other ones are saying, what about me? And so, they want it to happen yesterday, but our implementation team is meeting with all the primary care groups right now. We're trying to line this up, and getting the staff hired is a challenge too, hired and trained. So, thank you.
We'll have more discussion afterward, but let's. All right. Fancy. Slide transitions. Craig Hepp is Chief of Ambulatory Operations for the Billings Clinic.
Wow, I got a promotion.
Oh.
I'm actually the Director of Practice Management at Billings Clinic, but that's okay. I go by many names. But I used to be the Director of Primary Care, and so I'm really looking at those bottom people. That's the primary care leadership team, and so I'm really representing their work here today. Just real quick, Billings Clinic is an integrated delivery network, has been since 1993. We've got 400 plus providers, 25% of them primary care, spread out over 5 locations, which kind of comes into play in this presentation. We've been on an EMR since the late 1990s and enterprise-wide with Cerner since 2004. My big takeaway from this is integrated and a shared EMR does not equal a patient-centered medical home. It gets you close, it really does, and I thought we were. We went down to Denver and went to the NCQA application workbook in 2011. I thought this is not going to be a problem. We'll go back and implement this without a doubt. I had my little thing there, and I said, well, we can do a corporate application too, save a few bucks. You have to get 11 of the categories the same across all 5 locations. Started putting the documentation together, and lo and behold, my 5 sites weren't doing the same thing at all the different sites, and so I couldn't really move forward with an application in that way. So we actually had a lot of discussion about that. We kind of backed up and said we need to take a new approach to patient-centered medical home and not make it about the application. So this was kind of an outcome of a meeting that we had. We basically didn't have clarity around what we wanted between the different locations. We were doing different things. We all shared the EMR, same policies and procedures. It was just surprising to me, to be honest with you. Moving forward, we started to put together our stuff. It says this is what it means to be primary care at Billings Clinic. We are in the middle of this system that has everything to offer to patients. We've got a long-term care facility. We've got hospitals that all work for us. We all share the same EMR. We've got urgent cares open on the weekends, late into the evenings. Our patients flow back and forth between these groups, but that group of primary care people are the people that attract and retain patients for Billings Clinic, and we should be navigating their care for them is basically what we came up with. Now, I truly don't have OBGYN in this model yet, but they are part of that middle group that we feel like they take care of patients and attract and retain for us. But they are obviously not NCQA eligible for medical home, but we consider them into our grouping. We put together this little slide only from the standpoint you can be a medical home and not be the same shape and size, but you have to have the same foundation. You have to have certain infrastructure that makes it work. And so we were trying to just use a visual to move forward with our groups. So we got our physician leadership and our teams together. We gave them dedicated time to start doing that. We put them through some vision and innovation workshops. Came up with this vision. It's pretty wordy, but this wasn't meant to go externally. This was their work. This is what they wanted to do. So we put that in front of them. But then we broke it down into 2 big things for us to work on, the technical core and then some adaptive work that goes with this. And you can see all the other stuff that people put in there about optimized access, evidence-based medicine, engaging the patient. But then there's also the cultural work that goes with that. It's not just the matter of getting a tool that lets you go through those things. So, and Dr. Agnew really kind of nailed this for me one day. She goes, well, always before we were working on the technical, redesigning the flow of the office. We were doing all that. That's all we were really doing. We weren't really talking about population management. We weren't talking about prevention. We were in a fee-for-service acute care model going full speed ahead. So we made a commitment to start creating the team, start putting the place, we got some commitment from senior leadership. Let's put in nurse navigation. Let's put in outpatient pharmacists. Let's extend our use of non-physician providers. We got to start building the team and let them kind of grow up from the bottom. So this is kind of our track on that. Since July of 2011, we've added 6 ancillary resources, I would call, into primary care at this point in time. One of them's in the purple is an outpatient pharmacist that just got added this last October, senior assessment navigator, gaps in care navigators, and ED and follow-up navigators. Now, I call them all primary care navigators, but they're actually doing different work because we just needed to learn how to do that stuff. We really didn't know how to do it. So some of the results, we embedded 2 downtown that basically work with our ED and inpatient discharge patients for the big internal medicine practice at our downtown campus. They're making about 700 phone calls a month to patients. So this is quarterly data, so it's about 2,000 a quarter, where they're actually every ED patient and every inpatient discharge gets called by one of our navigators within 3 days. Tremendous amount of work that this saved us. We got people in, we got them moved back to cardiologists, back into surgery. So if they were PCP'd by Billings Clinic, they got a call from us. The other thing that really started happening here is we started making appointments for those people, and you can see this growth as we started adding in the gaps in care people and the other types of stuff. We were bringing people in that weren't getting their diabetes care, that weren't getting their hypertension care, identifying those through getting them into a pharmacist now when they couldn't get in to see a physician for medical management type of things. You know, because we're an integrated system, value-based purchasing, readmissions, big deal for us. One of the things that you could do to reduce readmissions is reduce admissions, you know, is what we kind of took at this. And so this is quarterly data, but for our fully navigated pods, which there's 2 of them downtown, and a pod for us is about 4 physicians and a mid-level and about 6 or 7 staff. So it's kind of a team that comes together. So we actually reduced an admission rate for the panel size of those people over the time frame. And I think the next quarter we're going to continue to see that downward trend as we move forward. And we haven't adjusted for seasonality or any of those types of things yet, but we're seeing some raw data movement. Not quite as big an impact on the ED visits. We actually expected that to go down a little bit more but our big issue here is still access for us. We do not have very good access. And so, I wish it was better, but I just can't say much about that. Here's some our gaps in care chronic disease. These were RNs in the beginning because I know we'll transition to a lower level license, but I needed to put RNs in place because they're eventually going to do the other work for us. But they started working on our chronic disease management and saying, what don't we have documented in the system? So for 2 of our pods at our other West End clinic, they started reducing the number of eye exams not documented. Seems like trivial, but it always shows up on our PGP, MSSP, all those other types of things, these measures that start coming into place. This was a big change for us about a year ago. We traditionally have always measured the individual diabetes measures, you know, LDL, you know, but we finally started saying we're going to measure the bundle, because what we found is all of our individual providers were green and at goal. They're all NCQA certified in diabetes, but we weren't improving the care for every patient. You know, we were getting the LDLs done to meet target, but that same person wouldn't have their blood pressure under control. They wouldn't have this other type of stuff. So we actually started measuring what we called perfect care. And for us, it was blood pressure at 140/90, A1C less than 8, LDL less than 100. You had your triglycerides measured, your the foot, pneumo, and flu all done. So we actually started raising those types of things up in our system. And actually, you can see that we took several of our pods out at the West End up on that track. And as we've talked to some other groups, Geisinger and specifically, they had targeted 12%. So we felt pretty good about where we were heading on this model. The other really big thing for us was bringing patients into, and this was really actually, it moved our physicians way more than anything else that we've done, is we brought in patient partners. There's 3 of them actively working now, so there's groups of 4 patients that work with a pod. They have at least monthly meetings. In some cases, if they're working on a project, they'll meet 2 or 3 times in a month. But you can see some of the comments that they made, and when the physicians heard it from them, it was much different when they were hearing it from me. It was just an amazing difference to hear it from the patients than it was for me in a non-clinical setting. So this was an advisory session. Of course, we've got a really strong CFO, and where's the return on investment and this type of stuff? You know, decreased ED visits for us is a decrease in revenue. A decrease in inpatient admissions is a decrease in revenue because we're all on the same financial sheet. We did see a slight increase in some patient office visits. We did get some money from Blue Cross Blue Shield to project this model, but in the long run, we know that this is going to reduce overall revenue for the clinic, and we've got to move into those risk share arrangements. But our problem in Montana is the biggest group of people that we could manage is our own employees. You know, that's 5,000 people. We can't aggregate people enough to take risk on, and the payers can't either because most of the people are self-insured. So probably the other big thing that we found out with our physicians, it's still not easy to do the right thing within the electronic medical record world, to do what you need to do from a population health management. We're still kind of in that process mode. One of the examples that we used a lot was, well, why do we have to struggle with the physicians? And I heard him talk about it up at Brown and Tolan today when we were on the tour. The mid-levels should be seeing the follow-up diabetics that are in control, all this other type of stuff. And why is that so hard? Because, well, the physician should just tell them to go see them the next time. And we actually started taking that away from the physicians and just started scheduling them directly on. And they were all fine with that once their patients in those patient partners meetings saying, sure, as long as you've said your mid-level's okay, we're fine to use them. But they would never do it themselves. They would never actually say, you go see the mid-level. But if we did it for them, they were fine with it. And everybody was actually happier. The other big thing as we went through this, as you could see by our slide, is that this is not just about primary care. We're lucky. We're a very integrated system. We've had a shared record and a shared governance structure for a long time. But we really needed to start getting our specialty partners engaged in this and about some of those discussions about you can't send somebody to endocrinology when they're my diabetes patient from cardiology, you know, those types of things. And so those have really been engaging in the last several months. So that was just a real quick snapshot of what we've been doing at Billings Clinic, and I'm here to answer questions, or we'll wait till the end.
Like breast cancer screening, do you measure that also?
Yeah, we actually do.
How do you resolve the ACOG recommendation to start at 40 and U.S. Preventive Services task force to start at 50?
It's been a real interesting discussion at our organization because, you know, NQF actually pulled their endorsement from what was used to be. So we've settled in with the MSSP definition, which is basically is 2 over 40, and that's what our, you know, within 2 years once you hit 40. So everybody seemed to be okay with that.
Very nice talk, thank you. How does your pharmacist get the identify patients that he or she interacts with, or are they referred? Do you comb a database based on number of medications?
So we tried the referral method the first couple months, and he was sitting over there twiddling his thumbs. And so what we went to is to the pods, and we basically went to the schedules and said, any patient that's got more than 10 meds, we're going to have the pharmacist see them the 15 minutes before the provider sees them and actually give a report out and start doing that. And since we've started doing that, the number of appointments have gone up significantly, but it's also engaged them in a different way with the pharmacist. They didn't know how to use him before, and so now they're actually getting out of that office visit faster because they're not doing all that med management.
Are the pharmacists participating in getting the patient to the goals of care by making recommendations on a medication or pushing the dosage, things like that?
So that's the big struggle right now. And what we came up with was a recommendation sheet that basically said, you know, this person isn't at diabetes goals, they may be interacting with this. And so they're giving that as a recommendation to the physician now to change that medication coming out. Our hope is through this relationship, as they get to trust that person more and more, is that they'll allow them to start doing that. Oh, just one thing on the risk score thing, and I will plug Humedica one more time for here. We're actually using the HCC risk score that you can pull out of Humedica, to adjust our panel sizes. And we've only done this for 1 quarter, so I'm not quite sure how Body and our providers are, but it is another tool within that you probably all have access since you're sitting here at this meeting.
Tell us a little bit more about your patient advisory group.
Sure. This was Dr. Agnew's real passion when she brought those in. So we started off with, we brought 4 in. They basically have their own name tag. They went through an orientation at Billings Clinic. They have a monthly meeting. They've done stuff from review our advertising to review clinical flow processes and stuff like that. But now they have to have at least 1 meeting a month with the team that they're associated with. And our intent will be that we'll have at least 1 team per every location. And in some places where we have 4 teams in 1 location, we'll probably have an advisory group for all. So we'll probably end up with 7 or 8 advisory panels. And what we're working on right now is, do we need an overarching structure that says, you know, we got the advisory panel to the advisory panel. And so
Is there a formal selection in terms of the process?
we actually usually let the providers in the group nominate patients to that, from that perspective of saying, who do we think would be good? And to be honest with you, a lot of them, we target recently retired people that actually are still kind of engaged and want to do something but aren't quite sure. All right. Thank you.
Thank you, Fred. That was great. Sir. I'm getting quicker at changing slides here. Let's see.
Mine's short.
Okay. Excellent.
Yep.
All right.
Well, one of the advantages of going last is everything's already been said, and I'll probably repeat some of the things, but I'll make it quick. The other thing is that you've seen one medical home, you've seen one medical home. So everybody's is a little different, as you said. This is our version of it. We've named ours and are marketing it. It's called our Patient Care Compass. Some of our marketing materials that we're handing out to patients. Obviously, the theme is coordinating care and navigating care. So our group, we're a multi-specialty group. We were founded in '46. We're for-profit, physician-owned, fiercely independent, I would say. 105 physicians, 135 providers. I think one unique is we're 2/3 primary care, 1/3 specialty. A lot of multi-specialty groups are kind of the other way. So it was a good base to start our medical home on. We have 9 sites. We're in Colorado Springs and surrounding counties. We're not, statewide or anything like that. Umedica says we have 104,000 active patients. We believe it. 453,000 encounters, all kinds of visits, ancillaries included, but 265,000 office visits. And like a lot of people here talk, we're on Allscripts version 11.2 since 2007 is when we went live with Allscripts. Some of our services, we are semi-integrated, I guess, as physicians. We have our own hospitalist program. That frenemy analogy is true with our hospital systems. We are their dedicated hospitalist program in one of the systems, but we go to all the hospitals in town, which is 2 systems, each have 2 hospitals. We have a surgery center. We do urgent care, after-hour visits, some extended hours, own lab, radiology. You can see the services. A budding or growing health management wellness section, diabetic educators that we have, and developing a lot of the rehab programs, pulmonary, cardiac, that's been mentioned in other places, and infusion center. So our medical home, it's interesting. Everybody started about the same time, it seems. We were 2009. We kind of kicked it off. First thing we did is reorganized our office workflows, much like Brown and Tolan's example today. And we had a lot of similarities. We called a CCR, clinical care representative, is kind of our checkout person who coordinates all the care as they leave the office so that you make sure they get things done and get it all captured. We rolled it out site by site, got our level 3 NCQA certification. Took us all the way to March of 2012 to change the culture, to change the workflows, to try to get everybody on board. Somewhere in there, 2011, I think we did MU, Meaningful Use 1 as well. We put our RN navigators at the sites in earnest, really, starting in June. And as a result of certification and meaningful use, we were chosen in Colorado for the Comprehensive Primary Care Initiative pilot. All of our primaries, which is about 47 of them, are medical home certified. And so the CPCI pilot, I don't know if you're familiar, it's kind of like the Medicare shared savings, but it's interesting in that it brings in the commercial payers partnering with Medicare patients to give you a PMPM care coordination fee plus shared savings without risk. So the issue of how do you transform a practice in a fee-for-service world, we did do all the medical home stuff before we got this care coordination money, but now as a result of it, we are now able to use this pilot, 4-year pilot, to give us the resources to actually do some of this transformation. And then, of course, we went live with Humedica in February, just 2 months ago. So everybody's talked about their team, and this is our version of it. A physician whose function is to manage the panel and, of course, to see patients. The NP or PA co-manage the panel, same issues, how many acute care they're seeing, how many chronics, that kind of thing. We have some 1-to-1 ratios, but we generally have a 1-to-2 ratio, one doc, one NP for 2 docs on average, just by geography. That's all the space we had. RN navigators, our version of that is we focus them on what we consider the highest risk. In the absence of having all the data of what is the highest risk, we chose post-ER, post-hospital follow-up and transitions of care. And we have currently, and they're embedded in the primaries offices, so there's one of them for 9 doctors' practices. But when you look at that ratio and you focus their efforts on a smaller segment, that works. They actually make the same calls to every post-ER, post-hospitalized patients and coordinate that care within 48 hours, and the goal getting them in within 10 days. Our version of population management is a team MA, where we have one we've hired for every 3 docs whose job is to do pre-visit assessments, to also do population management outreach. We believe now that we have Humedica and we'll be getting these gaps in care and these work lists out of it, that these ratios may change a bit because there'll be much more of that work being done. Our regular MAs, enhanced intake, medicine reconciliations, and then, as I mentioned, our clinical care rep that basically completes the visit and coordinates the care. So what we've had to develop along the way is essentially a whole new department called our Clinical Innovation Department that's job is to support these care teams. So we've centralized some of those functions instead of putting it all out there at the site, because the sites are still busy with their own workflows and trying to take on the analytics part or new workflows is difficult. So we have an analytics team with a data manager, analyst, IT support, our EHR MD champion, and of course Humedica at the foundation for our data. And then we have on the other side, the care coordination team, we have the champions committee, essentially the site-based kind of engaged leaders with the administrative dyad going to try to help us with implement whatever this group decides to is the best way forward. I think somebody else said it, it's getting the medical homes don't look alike by site, but the core, the foundation is the same, and that's the idea. So just some data. This is a group of patients that we actually a Medicaid, we belong to a managed Medicaid population pilot. And we had in our group, we had 21 frequent flyer ER types that go to the ER a lot. So you can see these 21 patients in October made 40 visits to the ER in 1 month. And in July of 2012, when our RN navigators started reaching out and calling everybody after every ER visit and educating them on, you do have a primary, come on in, we have urgent care alternatives. You can see we brought it down to 5 to 6 on average. It's about a 2/3 reduction in the ER visits, and of course that translates into savings. Another ROI for the CFOs in the room, or the ones that have to report to CFOs. In March, we have 3.8 navigators, FTE navigators. They made 948 of these post-ER hospitalized visits, and that generated 316 appointments, both to primaries, to our specialists, to ancillaries, that we would have captured some of these. They would have had follow-ups anyway, but maybe not, and that's the issue. So that's a 33% capture rate. Every 3 calls yielded at least 1 appointment. Our net revenue for visit across the board of the organization is that, 316 visits, net revenue in March from just a visit standpoint minus the expense allocation. So a rough, crude ROI, but indeed I think it proves you can, if you're in a fee-for-service environment, make money by increasing your services. And it's better care, of course. And when you transition to value-based or total, cap pay, you will obviously save on the high-risk cost. This is cost data from one of the payers in our area that compared our group to the market. And I like this slide because it basically says when you look at total cost, and you're not just looking at a primary care or doc services only, and you're looking at the big picture, you can indeed save money, 16% say a cost advantage over our competitors in our market. But you see, we spend more on professional services. We spend a lot less on facility inpatient, facility outpatient. We're about even on the other medical services. And so that's the coordination of care. We have a SNF program. We coordinate care across the continuum. So those are the data I have. So the next steps for us is for the docs now to get their individual data. We've done all this while we've engaged Humedica, getting it up and involved. Now we're at the point, I think, the fun part, because we get the data. We can go out there and show these people, both patients and docs, what we're doing. And, our next steps, what has been mentioned here, social workers, psychologists embedded. We do have a pharmacy. They're not really involved yet, but we have a limited staff. But we're thinking about, after hearing this, we may engage our pharmacists. We think we're going to need more RN navigators as we go forward, because the scope of their work's, I think, going to increase. And that was it. And I have any questions?
Did you? Hello? You said your hospitalists are employed?
They're employed by our group, right.
Do they see patients for other groups as well?
Yes, we admit for probably, at one hospital system, about almost 99% of primaries. And we've actually engaged those in, they're very interested now in transitions of care, because there's a new Medicare code that pays for that. So now they're very interested in our communications at discharge, like we do to our own docs when we discharge from the hospital. We have a voice mailbox system, actually, that the hospitalist, discharging hospitalist, gives a phone call and records a message for the PCP. And inside our group and outside, for those outside docs that want it. And that's actually been very good. We send discharge summaries and faxes that they were in, but the phone call is a quick way to transmit a lot of information without disrupting the PCP's schedule. So we feel that that's been a very positive thing. In our organization, the RN navigators listen to those calls. And that's one way they know that the patient was in the hospital and discharged, but they also pull from the hospital data.
Have you measured any impact yet on how busy your hospitalists are, or have they been impacted?
Sorry, we just had a few operational issues on the way out here with our hospitalists. They're getting busy, and it interestingly, when we look at our utilization rates of our group PCPs with this program versus the outside unmanaged, we'll call it, we're admitting more of the unmanaged population from outside primaries, and of course we do the unassigned call as well, so that seems to always be going up.
So you could just use that outside revenue to finance your PCMH?
Oh, it does, and of course the hospitals, have a payment for taking the call, so it is helpful. So, okay. Thank you much. Oh, you have a question? You catch me later if you want, or sorry.
So real quick on your CDEs, I assume they see commercial patients?
Oh, yes.
And so how do you get that funded? We're having some troubles. Our commercial payers only pay for RDs, for example, and we can't. And we're trying to get it tied with an office visit so you can do an education and advanced medications and issue with Medicare there.
One of our RN navigators is actually a diabetic educator converted, and so she does some, and we do have RN navigator office visits. It's a level 1 nursing visit, doesn't quite cover the time, but those are the imperfections from fee-for-service transition to pay for value. I should say we've also changed our internal physician comp plan to reflect some of this. We're paying some of our primaries this care coordination revenue based on their panel size. So they have skin in the game. Thank you.
So just a few housekeeping items. All the documents from today, as well as for the rest of the meeting, will be uploaded to the web portal. Everyone here has access or will have access in the next few minutes. So if you see an email coming across that you have access, it's to the Ancetta Collab, so it's Ancetta, COLLAB.com. If you don't remember your password, it's fine. As you log in, if you're already a registered subscriber, you can log in and change it upon your initial login or anytime after that. So all the documents will be there so you can access them electronically. We are having a reception today, so it's upstairs, 21st floor, where we had our lunch. So it's from 5 to 6. There is some appetizers as well as some cocktails there, so to continue the discussions. Want to remind everyone that tomorrow afternoon we have a session on the agenda called Open Space. As you see on the whiteboard or the flip chart in the back and on the wall, we've put out a few topics to help the thought process go. The open space is an opportunity for more networking. That's what we always get on our surveys, is you guys love to have the opportunity to network. So while you're all together here of like minds, working on a similar tool, Humedica, it's a chance to discuss what are the hot topics. What do you want to, have some open space just to discuss. So what we would like to do is gather more of those topics, have some voting tomorrow morning, and at lunchtime we'll announce the top 2 topics, and that'll go into breakout rooms tomorrow afternoon. I think that's everything. Tomorrow morning also we are starting early, so we're starting at 7 a.m. here, and breakfast will be served as part of the opening session. So it's starting early, but we're wrapping up in the 4 o'clock hour for our dinner cruise in the evening. We have a few more items.
All right, well, thank you. So I just want to thank everybody from Brown and Toland for being such gracious hosts for our collaborative. It was a great tour. Fiona, thank you. Larry, Adrian, really appreciate that. And our other presenters today, people who were willing to talk about what they're doing and kind of how it's all fitting together. And there's a pattern emerging, which is really kind of exciting. And I think one of the things we want to do is talk more about that a little bit tomorrow morning. We'll have some some data that we've been working with the folks at Centera who've been working on patient-centered medical home model as well. So thank you for our presentations, and we'll see you at the reception in about half an hour if that works. Thank you.